Welcome to Basic Black. Some of you are joining us on our broadcast, and others of you are joining us on our digital platforms. I'm Callie Crossley, host of Under the Radar 89.7. Tonight, community health centers on the front lines. We, like you, are dealing with the effects of the coronavirus pandemic and are taking precautions. We are working with limited staff, and our guests are joining us remotely. Dorchester's Columbia Point opened its doors 6 decades ago with a mission to offer health care to patients of color and the poor. Massachusetts' first community health center is now part of a group of community health centers in the state, serving racial and ethnic minorities and low-income residents. Today, more than 1 million patients a year, 1 in 7, get health care at a community health center. During the COVID crisis, these health care centers made sure that communities of color got equal access to testing and vaccines. And the new Omicron variant has put these centers back on the front lines, picking up the slack from hospitals slammed with an overflow of sick patients. How are they managing through the ongoing pandemic while preparing for the next battle? Joining us remotely, Dr. Charles Anderson, President and CEO of the Dimick Center in Roxbury. Gregory Wilmot, Interim President and CEO of East Boston Neighborhood Health Center, and Dr. Guy Fish, President and CEO, Greater Lawrence Family Health Center. Welcome to all of you. Now, I've just described you as being on the front lines, or your institutions as being on the front lines. And I want people to, before we dive into what's currently happening, really understand where you are in terms of the spectrum of healthcare. So you're not solo practitioners, there's the hospitals, and there are the community centers. So just a brief, where you stand and who you serve, Dr. Charles Anderson, so people have a sense of what we talk about when we say that you all are on the front lines.
Sure. First of all, really appreciate being here and being able to have this conversation, because I do think it can become pretty confusing sometimes when we think about the role that we play and who we are. So at the Dimick Center, we're on 9 acres in the middle of Roxbury. We serve roughly 19,000 individuals on an annual basis. This is individuals who are receiving care across a spectrum, which can include primary care, obstetrics, pediatrics, dental care, mental health, eye care. And also on our campus, we have a shelter. We do substance use disorders. So we've got an inpatient detox, a clinical stabilization. We have a residential recovery homes on our campus, as well as a shelter for families on our campus. And let me not stop there. We also have Head Start, early intervention, and so an educational component. So I think it's really important for people to understand that federally qualified health centers are not just a place where someone receives traditional health care, but where we really care for all of the needs that that community requires.
And Gregory Wilmot, even though you serve a similar role, do common tasks, you're very different in how you may be addressing your particular community. So as you describe for me what your community health center, how its role manifests every day, explain a little bit of that about how you might differ from Dimick, for example.
Wonderful. And thank you again. Such an important topic. So East Boston Neighborhood Health Center is unique in that it's the largest community health center in Massachusetts. We serve about 120,000 patients per year, serving areas of East Boston, Revere, Chelsea, Everett, Winthrop. We also completed the first of its kind in Massachusetts, a merger with the South End Community Health Center in 2020. We operate a 24/7 emergency department. We are one of 2 federally qualified health centers in the country that operate a 24/7 emergency department. And that was really important for us to respond to the unique challenges of our community. But like the Dimick Center, we provide a wide range of services and very comparable to the Dimick Center. But we really try to focus on the unique aspects of our community, focusing on programs that are unique to what is a largely Latinx population.
Same question to you, Dr. Fish, the commonalities and what is unique to your community health center.
Oh, thank you, Callie. Pleasure being here with you. And hello to my good friends, Greg and Charles. Lawrence, the Greater Lawrence Family Health Center serves a community of Lawrence, Massachusetts, Haverhill, Methuen, and North Andover. We count 65,000 individuals that we serve in a population that is just roughly slightly larger than that. But what's unique about Lawrence is that since its founding in 1847, Lawrence has been an immigrant community. It was founded as a mill town. And the textile mills that were established here many, many years ago, first brought in the Irish, then followed by the Italian, and then finally by the Hispanic community. Our Latinx population makes up 70% of the town. We have a huge number of only Spanish speakers or bilingual speakers. So we have to be very sensitive to the needs of the immigrant community and the bilingual community, such that all of our services need to be translated and made available in 2 or more languages. We also do, as the other centers, provide behavioral health services, pediatric services. We do a whole range of testing, and of course, COVID has presented its own unique challenges, but we've risen to the occasion and have done an enormous amount of tests, probably 130,000 COVID tests to date through our health centers and clinics. So it's very much the immigrant community that we serve, and all others as well.
Okay, so now that we have a sense of where you all fit in these communities and the particular special and unique link you have to the communities that you serve, let's leap ahead to this moment in time where we've now been in COVID for, oh God, more than 2 years. And you all have had your ups and downs. We'll get to some of those later that, other health institutions have suffered. But we're at a critical point in this moment because of the Omicron variant, and hospitals are slammed. So your partner hospitals have an overflow of these sick patients. That puts pressure on what you normally do in your communities. Dr. Anderson, how are you able to respond, and what exactly are you doing to sort of mitigate that situation so that it best helps the community that you serve in Roxbury?
Sure, it's a complex challenge. And one of the things that we focused on immediately was how do we maintain a degree of access to the basic services? And as this started to emerge in this current surge, we said, look, let's switch to some of the things that we did in the past that had some degree of success. So what can we move to telehealth? And how can we leverage what we've learned from telehealth to do it even more efficiently and more effectively this time around? So we've actually kind of really thought through how we deliver our services through that portal, which has been really critical in making sure that we maintain a level of traditional access. Because what we did find is, as we were getting to a place in this pandemic, people were starting to come back. All the deferred and delayed care was starting to be addressed, and we didn't want to stop that. And so it was really this switch to telehealth, reorganizing the times of clinics, reorganizing the way clinics were staffed. And of course, a lot of that driven by the staffing challenges, because COVID also affects staff. So we've had to pivot almost on a daily basis to make sure that we maintain the level of access that the community requires.
Dr. Fish, does that sound familiar? Are you pivoting on a daily basis because of that overflow situation at hospitals, putting pressure on your center?
Oh, yes. One of the things that I should have mentioned in our intro is that we're a little unique in that we are the first community health center in the nation to establish a residency program. Doctors in training after medical school typically work in hospital settings for somewhere between 2 to 6 years. We were the first community health center to establish a residency program in family practice. Our partner hospital, Lawrence General, utilizes our residents and the hospital for their training. And just last week, we got a call from Lawrence General Hospital CEO who said, we're just flat out. We have the great quit of resignations that happened in 2021. We have the Omicron surge. We have more patients than we have either beds or nurses. Can your doctors help us? Can your residents help us? Our faculty, staff, and our residents have stepped up and are actually manning an entire floor of patients, 28 patients. So we get it very directly that way. The other things that we've done that have been helpful is going to a work from home when able status. Because again, many of our employees are our patients and our patients are our employees. So they're being devastated in their homes and families as well, but they still are mission driven and committed to the work. So we're making work at home, if able, available to all of our staff.
What is the pressure on your center that your residents are no longer available to you in your center now? They're at the hospital.
Right. We've had to shift our schedules considerably. It is at a loss to them of the direct clinical outpatient experience. And so the good thing is that we've been able to transition, as Dr. Anderson has said, to telehealth. And the benefit of technology is that you can actually turn patients quicker because you're not walking them back and forth. And so many of our other faculty and staff have stepped up to breach the gap with the residents at the hospital, picking up telemedicine shifts.
Gregory Wilmot, now your center, East Boston, you have a 24-hour emergency room, right? Center, am I correct? So that's unique in itself, and I don't know how that plays out between you and your partner, your hospital partner in this moment now with the Omicron surge.
It's been really important. So if you imagine during the surge, as things got started, it drove a lot of people to emergency departments. And so because we have that local community-based emergency department, we were able to take some of the pressure off of the BMCs and the MGHs, our local hospitals. We also opened up what we call an influenza-like illness clinic, an ILI clinic. And that really helped to ensure that persons that had flu-like symptoms or COVID symptoms were able to come see us. We were able to quickly identify and diagnose what might be the challenge. And for COVID patients, we were able to get them started in a course of treatment or recommend that they isolate. And so that really did help to manage the surge as things got going. We've also implemented COVID oral antivirals. And so, again, having the opportunity for folks to quickly get access in their community to treatment and then get on a course of treatment with the COVID antivirals, that was a helpful way to make sure that folks were not suffering from severe illness.
So one of the issues that has threaded through a lot of the situation you found yourself in under pressure from this particular pandemic had to do with equity. The head of the Mass League of Community Centers, Michael Curry, has said that there's often been a piecemeal approach to supporting community health centers, of which there are 52 in the state, and that there needs to be a holistic one, recognizing that racism is very present in healthcare, that your patients know that for real, live that, and there needs to be some attention paid to those access issues that really reared their head and became visible during this pandemic, and certainly even more visible whenever you have these kinds of surges. So, Dr. Anderson, how do you respond to that? Michael Curry is of the opinion that there ought to be an equity officer, actually, a cabinet level person, to oversee in a holistic way what's happening with the community centers that provide such a critical role in providing primary health care for underserved communities.
Yeah, there's no doubt about the fact that we need to apply an equity lens to everything that we're doing in healthcare, both at the community health center level, but I'd say at the hospitals, emergency rooms, really across our healthcare system across the country. One of the things that we find specifically is that we have to remember during this pandemic, the death rate due to opioids for African-American men increased by 70%. And we just stop and pause for a minute, think about what that means in terms of those men being connected to so many other family members in their community. And what we found that's been really critical in terms of that equity lens, and again, one of the unique parts we've always talked about here at the Demick Center is the work that we do in substance use disorder and our detox and clinical stabilization. And we've made the opportunity available, and we've done a tremendous amount of outreach to make sure that our services are addressing those unique needs of individuals at Mass and Cass, of 60% of whom are people of color, to make sure that we're creating beds specifically designated and actually leveraging our staff who actually mirror our community to be able to provide this sort of recovery coaching and support. And, quite honestly, you talk about this, how we're helping the hospital systems. We're having individuals who are being transported from hospital emergency rooms because they're overloaded, who actually need detox support, who are actually coming onto our campus and being admitted for those services in this way. So, we're actually looking at everything that we do to make sure we're addressing those gaps in care, and specifically those gaps in care that are more severely impacting those of color.
Dr. Fish, would a more intense or holistic focus on the inequitable access issues with regard to community health centers make sense to you, be better for you?
Absolutely, Callie. I'd like to draw a very sharp distinction between two things that get confused all the time. One is medical care and the other is healthcare. They're very different. We have great hospitals in Boston, world-class, galaxy-class hospitals that do amazing things for people that are really, really sick. But I don't run a hospital. I run a community health center, and the focus is on health. And when we talk about health, yes, we do some medical. We have doctors and nurses and nurse practitioners. We do medical things for our patients, but we're also focused on health, which means what are the things like nutrition or access to food, access to housing? How do you manage if you have economic constraints? And so you're choosing between your medicine versus your rent payment at the end of the month. What if your justice involved? These are all conditions, upstream conditions, we call them social determinants of health, which are part of how we have to look holistically at the people who walk through our doors, partner with other institutions that help solve these problems on a daily basis, and really lift the health of the community. So one of the things that I'm really delighted about, and we can talk more about this, I'm sure, is that the difference between healthcare and medical care often comes down to reimbursement. Mm-hmm. Hospitals have actually been dominating the flow of money from the state government and federal government with respect to payment and reimbursement. And community health centers have often been an afterthought. What we're seeing now with a reform that's coming through is increased payment to community health centers like ours. For medical care, the rates have gone up substantially, but also including behavioral health, substance use disorder, and other aspects of the care that we deliver on a daily basis, finally getting reimbursed.
Yes, and Gregory, as the reimbursement drop that happened, particularly during the early stages of COVID, was quite intense, 50 to 70% at community health centers. Governor Baker did provide a state bailout to community centers and was instrumental in raising some of those structural fees that Dr. Fish has referred to. So, but still, that's a lot of weight on community centers to provide what Dr. Fish and Dr. Anderson have made clear, which is health care and not medical care. And in the middle of a crisis, that's sort of a double whammy.
Absolutely. And Dr. Anderson and Dr. Fish touch on some really important issues. COVID taught us a lot about the challenges in our public health system. One thing I would add is that continued investment in community health centers as an integral part of our public health system is really important. We have greatly contributed to the state's response to COVID-19 in terms of access to treatment, access to vaccination, access to testing. access to rapid antigen tests now. And those are some things that we can continue to do for the next public health crisis that might emerge, or as we continue to recover out of this crisis. And so continued investment in community health centers as an integral part of the state's health system, absolutely important. We've been fortunate. We've partnered with the federal government on a number of aspects of our COVID response and our local state government and the Baker administration. And so that type of partnership and intentionality is absolutely critical.
One of the things I've learned from, just getting ready to have this conversation is while you are often underfunded, if you will, you have to deal in the moment of the crisis, but at the same time be looking forward about what you're going to do for your population and be sort of really on the cutting edge. So, in fact, most of you were offering the vaccines and the testing early to your particular communities. When the vaccine and the boosters, you're offering that early. And now, Gregory Wilmot, you mentioned earlier, you were turning to therapeutics, the oral medications. That's something I know all of you are looking at as a way to help boost the possibility of just regulating that everybody's well-being so that you don't have these dips back into crisis modes for healthcare. How is it that you managed to do? I mean, you're working on a shoestring there, Dr. Anderson, to do all of this. What can you say about how you are managing to do that?
I mean, there's several things. One, you don't do this on your own, right? We do it through our, amazing staff that we have, but also the range of partnerships that we have. But we have found during this pandemic that there are organizations and individuals who are also wanting to be part of this important work. Everyone's starting to really understand the value that community health centers can play, because quite honestly, we're the ones who built these trusted relationships with communities, and some of which go back over 100 years, like us here at the Demick Center, having been a hospital at one point and being where we are for 150 years. And many partners are starting to understand that if you really, really want to get to things like levels of vaccination across the state, you've got to really do that through community health centers and leveraging that trusted partnership that we have formed with the community. And so we've been able to do a fair amount of what we've done in terms of meeting needs in terms of food insecurity, et cetera, through large partnerships with places like Stop and Shop and others and big corporations that are saying, look, you are the ones to give us the return on this type of investment, because you're the ones that can really do this work where it needs to be done most.
Gregory, do you think that the silver lining of the crisis, if there is one, is that community health centers are on the big stage now, where people do have a greater appreciation for the value you provide?
I think that is a silver lining for sure. I touched on the important work that community health centers do as part of our just overarching health system. I do think there's greater appreciation for that as folks learn more about what those services look like and how vital they are to communities. I think the added silver linings is, the pandemic did shine a light on some gaps and really accelerate a number of policies that have benefited community health centers, but also have benefited communities served by community health centers, being able to implement quickly telehealth services, expanding behavioral health services, beginning to really build out a more comprehensive disaster preparedness response. Those are things that we can say were silver linings from the pandemic. But I absolutely agree that it has allowed community health centers to step forward, showcase the work that we do day in and day out. It's given us an opportunity to thank our most valued asset, our staff, and for them to feel really proud and good about the amazing work that they do every day.
So, Dr. Fish, I don't have much time here, but do you think that we should reframe and think about community health centers as canaries in the mine when we talk about healthcare? Like you see it first because you are on the front lines.
We are absolutely on the front line. And I think the point of that is that we serve the most vulnerable populations in our society. These are folks who in my community have literally just gotten off the airplane and need to be plugged into all kinds of systems. In the Dominican Republic, where a vast majority of my patients are from, the Central American style of getting medical attention is to show up in the ER. We know in America, that's the most expensive thing you can do. And it doesn't lead to long-term engagement about being healthful. It instead is a stopgap. So we are seeing the patients who are most at need and being able to address them and focus on the needs of communities like this only lifts the entire state in its healthfulness.
All right. Well, that's a good place for us to stop. That's the end of our broadcast, the end of our show. I want to thank all of you for joining us, and now stay with us as we continue our conversation on our digital platforms, Facebook and YouTube. I'm Callie Crossley, host of Under the Radar 89.7. We're on Facebook and YouTube with our post show, continuing our discussion on community health centers on the front lines. You know, one of the unique populations, well, not unique, but certainly significant populations that would be served by all of your centers are the elderly. And I think even if you want to drill down more, the frail elderly. And I wonder about what size populations of the elderly and the frail elderly are you attending to at your centers, and how have you seen their vulnerability change during the pandemic, I guess is the best question. And what have you been able to do potentially to mitigate some of that? Dr. Fish?
So the Lawrence community tends towards being a younger population compared to other communities in the state. But of course, we do have our elderly and frail elderly here. The pandemic has been awful because the elderly tend to be somewhat isolated to begin with. And that isolation intensified with everyone being afraid of the virus. So fortunately, we have some great partners here in the Merrimack Valley. We have those who are either participant organizations or members of PACE, which is a program for comprehensive care for the elderly. Our ability to network with them and to dialogue with them through our community health worker network to understand who needs services, what services they need, and provide those through our PACE program partners has been the way we've addressed it.
Dr. Anderson.
Well, for us, I think initially one of the biggest concerns we found with our elderly population was access to things like vaccine. And so by partnerships with the Black Boston COVID-19 Coalition and others, being able to get into those housing complexes and to be able to deliver vaccine for those who were isolated and less mobile was a big part of it. So it was, how do we bring those services to them at a time where it's so much more difficult for them to come out and get the sort of access. So that was our really primary focus during this pandemic, was how do we bring these services to those really fragile elderly population.
And Gregory, East Boston has a mobile unit. It has mobile units, right? As I recall. And was that part of how you addressed attending to the needs of the elderly and frail elderly in your communities?
It was a multifaceted approach, in fact. Dr. Fish mentioned programs for all-inclusive care for the elderly, PACE. East Boston Neighborhood Health Center operates a PACE program. In fact, prior to my appointment as interim president and CEO here at the health center, I served as the executive director of our PACE program, among other responsibilities. So when the pandemic hit, it's absolutely true, is amazingly isolating. When COVID came out, it was largely affecting the frail elderly. Were at risk of severe illness and death. And so it was important for those persons really to, where possible, avoid crowds and stay home. And that was very isolating. So we deployed a pretty comprehensive strategy to do wellness checks with all of our frail seniors, both in PACE as well as seniors served by the health center, routine calls, making sure that someone was talking with those seniors every week to find out how they were doing, both medically, but also just making sure they weren't feeling too isolated. And then we deployed our care teams into the homes with PPE, which wasn't easy prior to having the protection of the vaccine, to continue to provide nursing services and other necessary healthcare services in the home. Telehealth came along and also helped us with continuing to provide routinized primary care and preventative care to those frail adults. We then deployed the mobile units as well to help to roll out the vaccine and other key services. So it was great that we had the benefit of the PACE program in place when the pandemic hit, because we were able to really deploy that team in highly intentional ways.
Now, we've talked on this show about the devastating impact of putting off, postponing various other serious health needs because of the pressures of dealing with COVID. Now I'm interested that all three of you emphasized this is not putting off a procedure, because each of you have had to do that. Dr. Anderson, you talked about having to shuffle around on your detox program. Dr. Fish, you mentioned the medical residency, and Gregory, I know that you talked about various programs that you had to determine, are they urgent or important, and make a decision based on that. Having said that, what I was very fascinated about is that all of you have noticed an uptick in flu cases in your various areas, which suggests that people are, I guess, COVID fatigued, or maybe COVID is so overwhelming that flu seems like nothing, or they're taking it like nothing. But it's concerning, because this is not a postpone. This thing just comes. You didn't postpone it. Here it arrives. So, Dr. Anderson, how are you coping with that? Because flu can be quite dangerous in and of itself.
Sure. Well, part of it's just the nature of what we do in terms of addressing people when they show up and they're sick, or they're expressing the fact that they have concerns about being ill. We expected that we're going to see more flu this year because, quite honestly, relative to last year, when everybody was masking and gloving and doing everything else, by not doing as much of that, we expect that we're going to see this. So for us, it's in the category of just generally people showing up sicker and having the opportunity to really address a range of needs, that just becomes one of the things on top of everything else. So there's nothing specific that we're doing with that. We're just doing what we always do in terms of addressing those acute needs.
And they're showing up sicker because certain procedures have been put off, or just everything has gotten mixed up because of the COVID treatment?
It's all of that combined together.
Okay.
Right? We're seeing more in terms of hypertension, diabetes management, the things that we're having to do. I think it's really important to emphasize this, because as much as the spotlight is on what we do as community health centers, let's realize that what we're being asked to do is greater and greater. And so it's going to require more intentionality at both the local and the state level to make sure that we have the resources available to continue to do this work in an environment that the demands are going to be that much greater.
So, Dr. Fish and Gregory, are you both seeing the same thing with regard to, I know you are with flu, but are you interpreted it the same way that Dr. Anderson is in terms of what it means overall?
Yes. So if I can go first, the I've been in the position of President CEO of Greater Lawrence for 6 months and 2 weeks now. And when I got here, I was told that we had a consequence of COVID, but even predating COVID, an issue with a backlog on referrals, made much worse by COVID, when the specialty practices had to stop doing procedures and close down. We've been systematically doing, just as you said, Callie, we've been looking at urgent versus important, those two dimensions, and trying to work our way through this list. But it really gets to be quite painful when you look at a list, and some things like, dandruff, that referral you can put off for a while, but something like a heart condition, you really need to address that right away. The other thing that I would note, and so we've been working with our community partners on how to prioritize, how to automate and prioritize our list of patients that need to be seen by them, get them slotted in, address the barriers to access to specialty care. For example, transportation, right? If a patient is taking off time from work to come to our clinic, taking more time off and going to a different location to see a specialist isn't always so easy. So how do you facilitate that with transportation and other means? The other thing that we've been doing is, after you diagnose the patient and come up with a treatment plan, the next thing is, well, they may need medication. So how do you make that more accessible to patients as well? And my chief pharmacist has been an extraordinarily creative individual. We took one of our clinics that has an outdoor facing wall with windows, and popped open the window and created a walk-up booth so that people don't have to come into the building to be in a crowded space and be with COVID positive individuals. They can just right off the sidewalk, get their orders and keep moving. So there are ways that we can be creative in how we address both referrals and access to medications.
Gregory?
Similar experiences. I think the piece that worries me most is after the pandemic, the season of disruption and challenge around accessing services or maintaining management of your chronic illness it will have implication. And I think we're going to need to have a very thoughtful strategy on how do you re-engage some patients in management of their chronic illness to ensure that it hasn't been exacerbated. We are seeing emerging trends, particularly around depression and anxiety and other behavioral health conditions emerging in our community. So there are some challenges ahead for sure, and we're going to really need to fortify ourselves and prepare for what will become the new normal, and really working with our communities to kind of get us back to a good place. But I am worried that the data will show that the disparities that we work so hard to manage and mitigate, that we'll see some exacerbation of those disparities in some specific areas.
Well, money is always an issue. And I noticed that President Biden did pledge $1 billion to community health centers. I assume that's across the nation. I don't know how much comes to Massachusetts or has come. Have you all seen any of that money? I assume it's also part of the package of COVID relief. Any one of you can speak to that, because I don't know where to put that piece of information.
Yeah, if it's okay, I'd like to just say, as the largest community health center in the state, we did receive considerable funds as part of the ARPA relief funds. We've quickly kind of put those resources to use. We're redesigning some of our facilities, expanding capacity for behavioral health services, expanding capacity and effectiveness of our emergency department. So those resources do come at a critical time, and hopefully as we emerge out of the pandemic and gear up for the next chapter, we'll be ready.
Well, while you're talking, we might as well talk about the largest private donation made to your facility, right? Which one? You got the I can't even get it out. The two people who were ill-served elsewhere, who arrived at a community health center and then donated more than 3.5. It was to you, Dr. Fish, right? The Greater Lawrence.
Yes.
Yeah.
Philanthropy, particularly in the context of the pandemic and opening up the eyes of those who have been blessed to the service that we provide. The philanthropy has been incredible. I think, as Greg said, it's great to get federal support to fund catching up on many of the things that have been short funded for a long time. But to really do what we need to do, we need to build on top of that. We need to be forward leaning and thinking about the additional services, behavioral health being a key thing in the Commonwealth. In the Lawrence community, we made the headlines, unfortunately, again, about our kids in the high school having fights, right? The kids are just the most overt manifestation of what we're all coping with, which is a lot of stress under this COVID pandemic. So how do we, with a mind toward sustainability, build out the services that we need? Philanthropy has been a big part of that. And so we're very thankful to the Horns for their landmark donation of $1 million that set a cascade of other dollars that have come in as well. So it's been really quite a blessing. We've also had a lot of state support from our congressional representatives, Lori Trahan in particular, in putting forth earmarks that we hope will come through if we can get Washington working again. Now's the time to look about and figure out how to sustainably maintain programming that we've been long waiting, and now's the time.
I just note that a private donation of that size sort of underscores the silver lining we were talking about earlier, which is bringing attention to the role of community health centers. And these are people I don't think prior to their experience might have known that. And so by virtue of who they are, that actually opens up the story to more people. And I think that is, you actually can't pay for that level of attention and understanding, or beginning to understand what role there is to play. Dr. Anderson, what about this money from President Biden?
We've actually clearly, similar to both Guy and Greg, we've actually benefited from, philanthropy and just the amazing outpouring of support during this time period. What I am also seeing, which is very good, is that it seems like that's continuing, which is great. We were always concerned that people respond during the middle of the crisis of what is COVID, but we see people continuing to do that. The ARPA funding has been incredibly beneficial. We received a very nice bit there, $5 million to support expansion of our clinical stabilization services, which is after someone finishes detox, this next level of care, and where we had a gap in services there around men, especially during this time and what I mentioned. So, those are things that we're able to build on. But I think as my colleagues mentioned, this is still just early innings, I think, of us being able to see what's beneath the surface of this iceberg, right? Beneath the surface of the water, where we're going to continue to need to make the sorts of investments that are going to continue to allow us to say, look, we are going to need the type of support of partners, philanthropy, our congressional leaders. Congresswoman Ayanna Pressley has been amazing, Senator Markley, and the earmarks and things that have come through those mechanisms. But we're going to need that continued ongoing support because of the fact that we are now under a spotlight, right? And now followed by a searchlight that allows people to realize we have these opportunities, but in order to continue to capitalize on those opportunities, this level of support is going to be absolutely critical.
Well, I think that's a good place to leave this conversation. For sure, you will be back in these seats at some point, bringing us up to date on where you are and the mission that you follow. Thank you so much, all of you, for joining me.
Thank you, Kelly.
Thank you.